We're taking this, 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 we're taking with a pinch of salt.
Ladies and gentlemen, welcome to A Pinch of Salt, a podcast by ERA, the podcast where we try to ask simple but clinically relevant questions to get clinically relevant answers. My name is Andrej Kuberne. I'm a nephrologist from Slovenia, and you're listening to the episode on biostatistics, a very important topic, I believe. Medicine is certainly an art, but it is also a science, and we base a lot of our decisions on what the science tells us. And we should never forget that medical science is based on statistics. So if you get that wrong, you can get everything wrong. And one might say that getting the statistics wrong is a catastrophe because we can base our medical decisions on wrong data. That's a real threat. And because most of us struggle with statistics, we have asked Giovanni Tripepi to go through the most common mistakes in biostatistics. Giovanni is an epidemiologist from Italy, working at the Institute of Clinical Physiology of the National Research Council of Reggio Calabria. Giovanni, welcome to A Pinch of Salt.
Oh, thank you.
It's great to have you here. So let's just start off with the first kind of provocative maybe question. I hope it's not. I don't want to offend anybody, but from what I see from my own personal experience and people around me, you can divide clinicians, so physicians who mainly do clinical work, based on how well they know and understand statistics into three groups. Those who know and understand statistics poorly, those who know and understand statistics very poorly, and those who know and understand statistics very, very poorly. Would you, as somebody who really understands statistics, would you agree with that kind of rough assessment?
Okay. I see the humor in your classification, and I will admit that there is a kernel of truth to it. Indeed, many clinicians who engage in research part-time may not have extensive statistical training, which can lead to common pitfalls in study design, data analysis, and interpretation of results. That said, there are certainly exceptions. Some physicians, for example, develop strong statistical skills, especially those involved in epidemiology, clinical trials, or data-driven specialties. But in general, statistical literacy can be a challenge in medical research, which is why collaboration with biostatisticians is so important. So, do I agree? Thus, I might not strongly disagree with your categorization.
Yeah, I think you're right. There are certainly physicians who are very good at statistics, but they're, I believe, in a minority. And the issue is that most of us, even if we're clinicians first, will at some point go into research, at least clinical research. And if we do that, and if we do that poorly, it's a great disservice to ourselves, to our time. If we plan it incorrectly from the start, which sometimes happens. And also, all of us read papers, and if we don't understand the statistics, we're not interpreting the data right, I guess, or that could happen. So what are the three most common mistakes you believe medical researchers make when they're planning a research project, from your perspective, from a perspective of somebody who knows statistics?
I would say ignoring the sample size calculation, inadequately codifying variables during the data collection, and introducing immortal time bias in retrospective cohort studies. Ignoring sample size calculations can lead to enrolling too few participants, which may increase the risk to participants if the trial is underpowered to detect important effects or adverse events. This could lead to ethical concern regarding the risk-benefit ratio for participants. Sample size calculations are crucial for ensuring that a study has sufficient statistical power to detect meaningful differences or effects. Ignoring these calculations can result in underpowered studies, where the sample size is too small to detect a clinical relevant effect if it exists. As a result, the study may fail to provide reliable conclusions, leading to wasted resources and potentially misleading findings. Inadequate sample sizes increase the likelihood of false positive or also negative results. A false positive result occurs when the study erroneously concludes that a treatment is effective when it is not, leading to unnecessary adoption of ineffective treatments or interventions. Conversely, a false negative result occurs when the study fails to detect a true effect, potentially denying patients access to beneficial treatments. As for the other common mistake, inadequately codifying variables during the data collection, it is important to say that data collection is the process of gathering information from individuals as well as from medical or electronic records. Codifying a variable is the process of assigning numerical codes or labels to different categories or values of variables that are collected to address the study aims. This codification helps in organizing data in a way that allows or facilitates statistical analysis. In a study, by assigning codes to variables, researchers transform qualitative data into a format that is more easily quantifiable for statistical analysis. If variables are not adequately codified, several problems can arise during the data analysis phase. The other common mistake is introducing, it is a very common mistake, immortal time bias in retrospective cohort studies. This kind of bias occurs in retrospective observational cohort studies when the follow-up time is incorrectly classified. Immortal time refers to a period during which, based on the study design and the predefined selection criteria, the study endpoint cannot occur by definition. Immortal time commonly occurs when assigning an individual's exposure status involves a wait period, for example, waiting for the administration of a given drug, during which follow-up time is accurate. The waiting period is deemed immortal because patients in the exposed group have to survive until the treatment of interest is administered. Thus, participants are immortal as they must survive long enough to receive the exposure of interest. This bias is very dangerous because it alters, distorts the association between the treatment and the clinical endpoint.
Okay, so maybe just a couple short questions regarding the mistakes that you have pointed out. So sample size, obviously very important for particularly prospective interventional trials, but is it also important for retrospective trials? Should we do sample size calculations for retrospective data in trials as well?
When possible, it is important to calculate the sample size not only for interventional studies, but also for observational studies. For example, it is important to calculate the sample size for observational studies of comparative effectiveness, which aim to assess the effect in real life of specific drugs.
Yes, yes. And for codifying variables, you're talking about like giving 0 for male sex and 1 for female sex, so then you can use it in statistical programs, right? Something like that. Yeah.
Exactly. It is important that all the information that we have in a database is transformed in a variable which is expressed in numerical terms.
Yes.
0 or 1, for example, 0 absence of the disease, 1 presence of the disease, because this facilitates the data analysis phase without mistakes.
Okay, and for the immortal time, which you explained very nicely, how do you get rid of that bias, the immortal time bias? How do you compensate for that?
Okay, it is important, for example, when I define a patient as exposed to a given treatment, it is important that the starting of observation is exactly the date in which the patient assumes the drugs.
Yes, okay, I understand. Yeah, that's clear, completely clear. Okay, so now for the next question, like, what are the 3 most common mistakes or misconceptions made by readers when they're reading medical papers and trying to interpret what the data which is there really means? What are the common mistakes that we make as readers?
Okay, I would say misinterpreting the hazard ratio as an index of prognostic accuracy, misinterpreting the p-values, and misinterpreting analysis by strata in randomized controlled trials. For example, as for the misinterpretation of the hazard ratio, I read several papers in which the authors drawn prognostic conclusions about a given exposure only on the basis of the hazard ratio. As with all relative measures of effect, the hazard ratio is an index of paramount importance in etiological research, but per se, it does not provide information on the prognostic accuracy of a given exposure. In other words, a significant hazard ratio is a prerequisite of a candidate prognostic factor, but I cannot draw conclusion about the accuracy, the prognostic value of a biomarker only on the basis of the hazard ratio, because the accuracy can be assessed by other techniques.
Yeah.
As for the misinterpretation of p-values, a p-value of 0.05 indicates that if the null hypothesis is true, there would be a 5% chance of observing the data or more extreme results purely due to random chance. Thus, the significance of the effect must be interpreted in the context of its magnitude, effect size, and relevance to the research question. The p-value provides a kind of information. When the p-value is below 0.05, it means that it is unlikely that the effect that we observe is due to chance. And this is an aspect of the problem. In order to assess the clinical relevance of our finding, it is important to look not at the p-value, but, for example, at the absolute risk reduction, or, for example, at the odds ratio, or at the number needed to treat and number needed to harm, which are other indexes that we use in clinical epidemiology. Another common mistake is when clinicians misinterpret analysis by strata in randomized controlled trials. In randomized clinical trials, stratified analysis aims to examine the effect of an intervention within subgroups defined by some characteristics, for example, males and females, age below above 65 years, etc. Thus, stratified analysis may reveal effect modification where the magnitude or even direction of treatment effects can vary across strata. While this can provide information into treatment heterogeneity, misinterpretation occurs when effect modification is mistaken for subgroup difference in treatment efficacy. For example, we read a paper about a randomized clinical trial testing the drug A versus B. In the whole group of patients, A is superior to B. Then I look at the effect of A versus B in males and females. I see that in males, the effect is statistically significant. I look in females, and I see that the effect is not statistically significant. I cannot conclude that the treatment works only in males and not in females. I have to look whether the risk reduction in males, A versus B, is statistically different from the effect A versus B in females. And we can find this information in the forest plot in the p-value for interaction of P for effect modification. Thus, the lack of a significant effect in a given subgroup cannot be used to draw conclusion that in that subgroup the treatment does not work. We have to look at the p-value comparing the effect again A versus B in males and at the effect of A versus B in females. If this difference is statistically significant, I can say the efficacy of the drug is greater in males than in females. I can say so, but I cannot draw conclusions only looking at the effect in each stratum.
Yes, that's very important information. You see a lot of these analysis of the interaction, and it's good to know what they mean. And it's very common to make a mistake with this, and a very dangerous one as well. I wanted to tell to our listeners the issue about hazard ratio and prognostication is very well described in the paper that you co-authored in CKJ last year, Common Mistakes in Statistics. So people who want to learn more about it, please take a look at the CKG paper from last year. There's also a video that explained this very nicely. And for the p-value, that I think is also incredibly important because I didn't know for a very long time that, of course, the p-value, the significance of the p-value also is related to the number of correlations you're looking at, right?
Exactly.
So if you would take like many retrospective research, I would say, is trying to be hypothesis generating, finding some correlations that have not been known before. And of course, if you take 100 of these correlations and you say that p 0.05 is significant, then by logic you would get 5 that are there only because of chance. So that's a very dangerous thing to do. Yeah.
We say it is similar to a fishing expedition.
Yeah. You find something that is nothing, which is always very dangerous. So thank you for clarifying these 3 things. Now, what is your view as a statistician on number needed to treat and number needed to harm? I remember when these were started to be reported in research, it was quite an eye-opener with statins and other drugs when you saw that the number needed to treat was 60 or 80, and then you figured out that you had to treat 60 patients to prevent this particular, of course, outcome in one. And that seemed like quite an eye-opener. But then you also do not usually find number needed to harm because, of course, if you give an intervention, you want to know how successful it will be. That a measure with that would be number needed to treat. But you also want to balance that by how dangerous it might be. So do you think this should be mandatory for all interventional studies to provide the number needed to treat as well as the number needed to harm?
I strongly suggest to introduce or to report the number needed to treat and the number needed to harm in all clinical trials.
Mm.
It is also important to say that we can derive as readers the number needed to treat and the number needed to harm on the basis of the data which are reported in a trial. For example, imagine a trial in which we have, in the active group, we have 10% of events, and in the control group, we have 20% of events. In order to calculate the number needed to treat, we have first of all to calculate the risk difference. 0.20 in the control group minus 0.10 in the active group. And we obtain 0.10. The number needed to treat is the inverse of this quantity, 1 divided by the risk difference, 0.10. 1 divided 0.10 is 10. It means that we have to treat for a given time period 10 patients with the experimental drug to avoid one event, for example, death, myocardial infarction, etc., as compared to the control group.
Control, yeah.
The number needed to treat must be always referred to a time frame, okay, which corresponds to the duration of the trial.
Yes, yes.
The number needed to harm is conceptually similar to the number needed to treat, but it refers to the safety aspect of a trial. And for example, if I have the same trial, 5% of adverse events in the control group and 10% of the adverse event in the active group, again, I calculate the risk difference, I calculate the inverse, and I find, in this case, just to simplify 10, we can say every 10 patients treated with the experimental drug, we observe one additional adverse event as compared to the control group during the trial. Then, as you already said, the number needed to treat and the number needed to harms look at different aspects of a trial. Number needed to treat at the efficacy of the drug, number needed to harm at the safety aspect of the trial. I suggest to report both in any randomized clinical trials,
Yes.
or try to derive if we are readers.
Yes, yes. It's nice that you explained how you get the number because it's pretty easy, right? So that's very good to know. It's good. It's a good thing to know because it's not always reported, and it's a useful number to assess, I would say, probably clinical efficiency in a way, or harm. So the more you learn about statistics, I think the more you realize how little you know about it if you're not a statistician. So, because the harm of wrong interpretation and wrong trial design is so huge, do you believe that a biostatistician should be part of all medical research projects? Because that's how it sounds to me. I mean, I can learn how to calculate the sample size for sure, but there's always, the devil is always in the details. There's no guarantee that I'll make it right. What do you think about this?
Yes, I believe that a biostatistician should be involved in all medical research projects, especially those involving data analysis, experimental design, sample size calculation, or interpretation of results. Their expertise ensures that studies are designed properly, sample sizes are adequate, biases are minimized, and statistical methods are appropriate for the research question. This is crucial for generating reliable results that can influence clinical practice and policy. However, the level of involvement may vary depending on the complexity of the study. While smaller projects with straightforward analysis might not require full-time biostatistical support, having a biostatistician review the methodology and the results can still significantly enhance the study rigor, credibility, and the quality.
Yes, you make a very strong argument, and I completely agree with you. But then, of course, the issue is how realistic is this? I mean, there's a limited amount of people who are in the business of biostatistics. How to reach one if you're not part of a huge team? Do you think it's realistic to have more research being checked by statisticians in Italy, perhaps where you work, or somewhere else?
It's not easy to have at the disposal a biostatistician for all research projects, okay? But I believe that if researchers are able to create network and with other centers, other groups in which there is a biostatistician, I believe that this can be possible. In any case, another suggestion by me is for scientific societies like ERA or other national level societies, for example, to organize during a national or international congress specific courses dedicated to biostatistics arguments in order to inform clinicians about some statistical approaches that can be also performed by clinicians by themselves. It's not always necessary a biostatistician. There are some statistical analysis of a basic level that can be also performed by clinicians. Of course, the involvement of a biostatistician is absolutely necessary when we want to design a trial or to apply advanced statistical methods.
Yeah, which is often the case nowadays. So I'm interested. I know the field of music a bit. I've been involved in music recording and stuff, and there's an interesting model there now where every recording you have to mix, right? Somebody has to change the knobs for the equalizing and everything. And now all of this is almost done all online. You have groups of people who are record producers who you can engage online. Maybe in some point of the future, we could have an online biostatistical community that you could engage from a distance, from just sending the proposal. Maybe that would work. Yeah,
I agree. My research group, I have 4 colleagues who are biostatisticians that work with me. And on the basis of the interconnection of the scientific network that we have, we assist about 10 groups at the national and international level in the field of biostatistics.
Wonderful, wonderful. That's the future, I think. Yes. So for the last question, that's getting to know you type of questions. These are always interesting and revealing. I hope you're willing to answer. So which book, 2 songs, and luxury item would you, Giovanni, take to a desert island or one of the beautiful Italian islands?
Great question. The book, The Count of Monte Cristo by Alexandre Dumas. It is a long, gripping story of survival, revenge, redemption, perfect for rereading.
Yes.
Songs. Here Comes the Sun by the Beatles for optimism, and Bohemian Rhapsody because it is a masterpiece that never gets old. As a luxury item, I would say a solar-powered e-reader loaded with the books.
Okay, very good, very good. I see you thought this out. Good, great choices, great choices. Thank you. Okay, Giovanni, thank you very much. We're very great. I'm very grateful, and I think our listeners will be also for hearing these pointers, this insight that you gave us. I hope that we'll be able to find ways to work with more biostatisticians in the future. Thank you for doing your work. It's essential for medicine, and thank you for doing this podcast.
Thank you very much for the invitation and the very nice questions. Thank you.
Thank you. Bye-bye.